Recording in progress.
So we are on live, so we are going now.
Select.
Madam, you're not
Madam,
visible.
you're not
We'll
visible.
start.
We'll start.
So just give me a moment here.
Yeah.
Yeah.
This is,
Hello.
Hello.
yes,
What the
sir.
voice is
Oh, the voice is
echoing?
echoing.
For me?
No. I'm telling IT team.
IT team.
Yeah, okay.
So your voice is getting
Yeah. Why it could be so? I don't know. That's okay now, I suppose.
yes, sir, it's fine now.
Yeah.
Yeah.
Madam,
That's
चालू करतो हा.
हो sir.
Tanvi, I'm starting. Hello, good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. Doctor, this program, as you know, is brought to you by Hetero Healthcare. Hetero Healthcare is an innovative pharmaceutical company with 35 years or 33 years of excellence. Hetero Healthcare has 25 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is amongst the largest closely held pharmaceutical company in India. Hetero Healthcare is the largest manufacturer of ARV, APIs and FDFs in the world and is Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's program, Experience Sharing Program on Managing PPS, Case Studies from Labor Room. We have got Honorable Speaker Dr. Kalyani Pawar Chowdhury with us. Welcome, Madam.
Yes, sir. Thank you, sir. Thank you so much for
Dr.
this kind
Kalyani Pawar Chowdhury is an experienced consultant gynecologist with over 10 years of clinical practice in Ahilyanagar. Madam is owner of Swastik Maternity Home Hospital, Savedi, Ahilyanagar, infertility consultant at Suyash IVF, associate professor in VK Patil Medical College. Madam specializes in high-risk obstetrics and infertility management. Madam is DNB in obstetrics and gynecology, DGO, diploma in gynec and obstetrics from GS Medical College and KM Hospital, Mumbai, and MBBS from BG Medical College, Pune. Madam is recognized for outstanding contribution to women's healthcare in Ahilyanagar. With this brief introduction, I once again extend a warm welcome to Dr. Kalyani Pawar Chowdhury, and over to you, Madam.
Thank you so much, sir. So today we would be discussing about PPH and the role of carbetocin majorly in the management of PPH. As we all know, PPH is loss of at least 500 ml of blood loss during normal delivery or more than 1000 ml during an operative, that is C-section delivery. PPH is common and it can occur even in women who are not at risk. It is a leading cause of maternal mortality. It's unfortunate, yet it is the major cause of maternal mortality in India, which contributes to 38% of the total maternal deaths which is occurring in India are because of PPH. It is a leading cause of maternal mortality. In developing countries where the maternal mortality ratio is 240 per 1 lakh live births, whereas in developed countries it is just 16. So we can imagine how much the PPH is contributing to the maternal mortality in the developing nations. As we all know, the etiology of postpartum PPH, it is the 4 T's, that is tone, thrombin, trauma, and tissue. Tone when we are talking about, it is about the uterine atony, where uterus is unable to contract. Thrombin, where we are talking about majorly about the coagulopathies, where there is, failure in clotting mechanisms. Trauma, when there is injury to the birth canal, rupture or uterine inversion or any lacerations, here we are talking about under the heading of trauma. And tissue, when there is retention of placenta, clots or abnormal placenta. Clinical findings in PPH, they usually depend upon what is the degree of shock. And degree of shock depends upon how much is the amount of blood loss. So in the female usually compensates for about 10 to 15% of blood loss, that is up to 1000 ml, where you would not see any changes in blood pressures, and the symptoms would just be palpitations, dizziness and tachycardia, which is often confused with the normal symptoms, which most often the patients show even normally after delivering the babies. In mild degree of shock, the blood loss is from anywhere from 1000 to 1500 ml. But here there is slight fall in blood pressure and there is weakness, sweating and tachycardia significant. Whereas in moderate degree of shock, the amount of blood loss is 1500 to 2000 ml. There is marked fall in blood pressure and there is restlessness, pallor as well as decreased urine output. Whereas in severe degree of shock, the blood loss is huge, that is 35 to 45% of total blood volume. There is profound fall in blood pressures from 50 to 70 millimeters of mercury, and the patient is collapsed. There are symptoms like air hunger, and even no urine output is seen at this stage. So the degree of shock the management depends upon the degree of shock. When we say about tone, that is poor uterine tone, uterus often feels relaxed, boggy, soft. The height of the uterus is usually above the umbilicus. It could be just because of the retained placenta, or it could be filled with blood and blood clots. In such a patient, if the immediately we have to see for the full blood count, coagulation profile, urea, electrolytes after the clinical examination. And abdominal ultrasound can also be done just to exclude any rupture or intraperitoneal bleeds. The management primarily depends upon the role of oxytocics here, prostaglandins and ergot alkaloids. Then uterine balloon tamponade is one physical method which can be used for control of bleeding in such a cases where the bleeding, the atony is the cause for PPH. Then tears and trauma here, the bleeding is usually from the site of trauma within the genital tract. It could be rupture, it could be lacerations, it could be for nasal tears, cervical tears, or in C-section deliveries, it could be extension of the uterine angles. Then in such a case, inspection is done thoroughly. Like after normal delivery, we have to very thoroughly examine the entire vaginal tract. The cervix has to be traced entirely in 360-degree to notice any sign, any evidence of any cervical tears. Then ultrasound helps in such a cases only just to identify the uterine rupture. Management again depends upon identifying this trauma, the site of trauma, and then the proper and thorough repairs. Retained tissue, here we talk about whenever the placenta is retained or the membranes are retained. In such cases also patients can bleed from anywhere from more than 24 hours to a month maybe if it goes undiagnosed. uh, Such a patient should undergo examination under anesthesia, because here we are going to thoroughly inspect the uterine cavity, which could be painful, hence under anesthesia. The management, of course, is manual removal of placenta. Again, it has to be performed under anesthesia. The fourth reason what we saw was thrombin, that is coagulopathy. Here, the bleeding is continuous, though the uterus is contracted, while the bleeding is continuous. Here we have to run all the battery for coagulation profile, and then the management is both, of course, medical and surgical. Actually, I want to go to the next slide and then come to this slide again. It's not, yeah. So then the treatment of PPH is majorly, we know, as of, the uterotonic agents. Uterotonic agent, which we have been using since ages, is oxytocin. Now we have introduced carbetocin into our practices. Ergometrin is again a traditional drug. Symptometrin is not used very commonly. It is, of course, a combination of ergometrin plus oxytocin and misoprostol, of course. So the timing for giving. So one is prophylactic management of PPH, where we do not want patients to have PPH. So in such a case, a prophylactic management of third stage of labor is done. By this, we mean that we are giving a uterotonic agent, either of the four stages, what has been mentioned at the time of administration. Some consultants do follow, at the crowning of the baby's head. Some give it at the delivery of the anterior shoulder. Some give it after the delivery of the baby, before the delivery of the placenta. And some follow it following the delivery of the placenta. If you ask me, the ideal time would be at the delivery of anterior shoulder or after the delivery of the baby, even before the placenta is delivered. So this is often a this prophylactic use of uterotonic agents is just to prevent atonic PPH. Actually, I want to go to the slide of carbetocin again. Yeah. So then we have been studying oxytocin molecules since quite a long time. Carbetocin is a wonder drug, I would say. Previously, it was not so popular because the heat stable formulation was not available. But with the invent of this heat stable formulation, it has made life of obstetricians very easy. When we compare oxytocin and carbetocin, which we would be, of course, oxytocin and ergot alkaloids, they often require a cold chain. They have to be, have to be kept in between 2 to 8 degree Celsius. Uh, they have to be kept at this temperature just to avoid the degradation of the drug and to maintain the efficacy. And resource poor countries will usually not have these cold chain facilities. Previously, when carbetocin was not available in a heat stable formulation, we had to face the same problems as we faced with oxytocin. But with this heat stable formulation, the half shelf life is 24 months at 30 degrees Celsius, and it is and 75% of humidity. It does not need this cold chain storage and logistics, and it is provided in a vial. And it can also be used in resource poor countries. So it is a synthetic long-acting analog of oxytocin. It is used for the prevention of PPH, of course, which is occurring because of the uterine atony. One vial, it is available in 1 ml vials, and 1 ml contains 100 micrograms of carbetocin. Lots of trials have been conducted for, carbetocin, just to compare it with the oxytocin, which we have been using it since a very long time. So as we see a comparison, lots of comparative studies, lots of outcome studies for carbetocin have been conducted. So one trial which was conducted just to compare oxytocin and heat stable carbetocin, it was found that there was not much of difference between oxytocin and carbetocin in terms of efficacy of the drug to prevent PPH. Oxytocin, as we know, it binds to oxytocin receptors in the uterine myometrium, simulating the contraction of the uterine smooth muscles by increasing the sodium permeability of the uterine myofibrils. Whereas carbetocin, it binds to oxytocin receptors. It results in rhythmic contractions, increased frequency of these existing contractions, and increased uterine tone. Oxytocin is given when it is given administered intravenously. It's immediate action with peak concentration occurs after 30 minutes, whereas sustained with the IV administration of carbetocin, sustained uterine contractions occur within 2 minutes, lasting for about 6 minutes followed by rhythmic contractions for up to 60 minutes, which is, of course, better than oxytocin if we compare. Intramuscular, of course, has got a slower onset of action in oxytocin, which takes 3 to 7 minutes, but produces a longer lasting clinical effect up to 60 minutes. Whereas in carbetocin, if we see, sustained uterine contractions after IM dose last for about 11 minutes and rhythmic contractions for up to 120 minutes, that is almost double that of oxytocin. The half-life is also 1 to 6 minutes, whereas half-life is 40 minutes for heat-stable carbetocin, which is also more than oxytocin. Oxytocin, of course, has some restrictions on its storage and transport point of view, where we have already seen that it requires a cold chain 2 to 8 degree to maintain its efficacy, whereas heat-stable carbetocin does not require such preconditions. Oxytocin can be used for induction of labor, for augmentation of labor, for prevention of PPH as well as treatment of PPH. This is one limitation which we see in heat stable carbetocin, that it can be used only for the augmentation of labor. Prevention of PPH, whereas it cannot be used for induction of labor, augmentation of labor, or treatment of PPH. Then there was one more trial which was conducted by WHO Champion trial. I'm so sorry, the slides are taking little time to.
Absolutely no problem, madam.
Can you help with the next slide? I'm not able to. Tanvi, can you push me on the next slide? Yeah. So Cochrane review was also done considering carbetocin for preventing PPH compared to oxytocin. So that also found that it is associated with less blood loss. This trial was done in comparison with symptometrin. So it was found that carbetocin was associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer adverse effects. So when we consider, when we want to use any drug into our practice, we often take into consideration like what all global bodies have approved this drug. It gives the authenticity for, its safe usage in our clinical practices. So according to WHO also, the carbetocin is one of the drug of choice for prevention of PPH, which has got comparable effects as that of oxytocin. And lots of other global bodies like SOGC Canada, RNJCOG New Zealand, FIGO, Germany, Austria, Swiss body. So everybody recommends carbetocin as one of the line of treatment for prevention of PPH. So my experience has been, this. Let us go through a few case studies. 24-year-old, gravida 4, para 2, living 1, death 1, abortion 1, previous 2 LSCS. This was just a case which we operated last week. She was a known case of PIH. She had normal lab parameters, but she underwent LSCS for an obstetric indication, that was severe intrauterine growth restriction and oligohydramnios. To my knowledge, I have been using this heat stable carbetocin for the past 2 years. And whenever it is an elective section or something, we always prefer to use carbetocin as the first line of treatment, because from my past 2 years of experience, I have noticed that, no repeat dose of any other uterotonic agent is required. So after patient received injection carbetocin after the delivery of the baby, and uterus was well contracted, and patient showed no signs of atonic PPH. Case two, we had this primey who had an IVF conception at the age of 35 years. She had a known case of hypothyroidism. She underwent elective LSAS again at 38 weeks in view of cephalopelvic disproportion. She received injection carbetocin, which has become our routine protocol. We have stopped using oxytocin in elective cases and in cases where we do not anticipate, PPH of March. So we prefer injection carbetocin, and uterus was again well contracted, which showed no signs of atonic PPH. Third case, she was a primey, 39 weeks. She went into spontaneous labor, delivered uneventfully. Normal deliveries, we usually had a protocol of giving, 10 units of injection oxytocin intramuscularly after the delivery of the baby, before the delivery of the placenta. But for the past 6 months, even in normal labors, I've started using injection carbetocin. And we have found no cases of PPH where the patients have received timely injection carbetocin.
Madam, thank you very much for sharing your cases. I'm sure doctors will benefit out of it. Now, in all these three cases, you said you have been using carbetocin. You have been
Yes.
using IV form or IM form?
Sir, I've been using IV form.
IV form. That's
Yes.
possibly because in the hospital settings, anesthetic is also available and IV is also relatively easy.
A protocol of securing an IV access whenever the patient comes into labor.
Correct, correct.
Then IV access is easy, I guess, compared to intramuscular.
Absolutely. And you get a
Yes,
faster onset of action to begin with,
yes,
which is
yes.
also very important.
Yes, sir.
Yes. And all three cases were different, both were planned LSAs and one was normal delivery, one was with
Yes, sir.
growth retardation, but everywhere carbetocin worked. That was the best part of it. And
Sir,
yes, madam?
to be very honest, I have stopped using oxytocin for
That's
the
lovely.
cesarean cases.
Yes,
And
yes.
for the past 6 months, I've also introduced this carbetocin in the labor room protocols, like after the deliveries.
That's
So
lovely.
even that is working well. And I often see that, the side effects are also not much. Like they're not
Absolutely.
there only.
Absolutely. Possibly
Yes.
one of the biggest advantages is it does not require refrigeration.
Yeah, yes, sir.
Just coming
That
to
is
this.
one thing, in
Yeah.
a bigger setup, you don't really get to monitor all these things very
Absolutely,
closely.
absolutely.
Sometimes
Yes,
it
yes.
is the negligence of a staff also.
Yeah,
Sometimes the
correct,
office
correct.
is
In
not
big
kept
cities, yes, in big
clean.
cities, big places, that is a problem. In small places,
And
there's no facility for
why
refrigeration.
oxytocin is not working, why, even
Yes,
in
yes,
spite
yes.
of giving 20 units, why the patient haven't stopped bleeding or
Correct,
something like
correct,
that,
correct,
then you
correct.
come to know, oh, that the drug was not well stored. So to, just tackle with all these things,
Absolute,
carbetocin
absolute, absolute.
wonders.
And you know what? Every minute or every second will matter in PPH. We know that.
Yes, sir. Yes, sir.
Yes. Now, coming to this panel questions,
Yes,
what is
sir.
the benefit of using? Now, you have been using carbetocin as the first line in both the cesarean as well as vaginal deliveries, and
Yes,
you have
sir.
noticed almost for prevention of PPH, and you have not almost not noticed PPH in any of the patients, right,
Sir, no,
madam?
sir.
Yes, that's lovely, and that too without any adverse effects.
No, sir. No, sir.
That's
No
good.
adverse effects.
So it's always
My anesthetist has also become very comfortable using
absolutely.
carbetocin, pitocin,
You know what?
oxygen.
Just sharing one experience. One anesthetist told me once, when I'm giving carbetocin in one patient, I can very immediately go to the next delivery table.
Yeah, sir.
I mean, in multiple hospital settings, that is possible. Government
No, sir.
settings, etc. Yeah.
No, because the drugs which require cold chain or the
Correct.
temperature, these things are there.
Monitoring.
You cannot really assure the efficacy of the drug.
Absolutely, absolutely.
Yes.
So definitely, carbetocin should be used as the first line drug for
Yes, sir.
PPH.
I totally agree with this, where you are not, the patient is, yes, sir, provided the patient does not have pre-existing coagulopathies where you are anticipating active PPH or something like that, then yes, of course, it should be used as a first line drug.
Correct. And although we can anticipate PPH in any patients, generally, which are the patients who are more likely to get a PPH?
Yeah, sir. PPH often occurs in patients who have been into prolonged labors, like for a quite longer duration, they have been into a labor process. Second thing is where instrumental delivery is often when we apply this forceps,
Okay.
then the patient might, have these lacerations or something, and they can, if they go unnoticed. Third thing is when the patient already have pre-existing coagulopathies, as I told you,
Yes.
like, severe PIH patients with deranged LFTs or acute fatty liver of pregnancy or something,
Correct.
such conditions,
Correct.
we can definitely, then the twin gestations, placenta previa, like abnormal
Yes, yes, yes.
placentations.
Bapre.
So all these cases, we can anticipate PPH. So
Anemia is another possible cause where you can anticipate a PPH.
anemia per se cannot be directly, even a small amount of blood loss can land the patient into PPH.
Yeah, yeah, yeah. The whole hemodynamics will get disrupted.
So basically, she would not fit into, we cannot wait for 5,000, 500 ml or 1000 ml
No,
of
no,
blood
no,
loss.
no, 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 no.
Even a slighter amount of blood loss, which could be
Correct.
less than
Correct.
500 in normal delivery or less than 1000, can also land her into PPH, sir.
When I was working in the peripheries of Mumbai, I mean, the highest hemoglobin that we ever got was 5 and 6.
Yes, sir. Yes, sir.
Yes. I'm sure अहमदनगरला तसंच असणार.
Nagar luckily has got the highest hemoglobin level up to 6.
Lovely. That's so nice to hear. Huh?
Yeah.
I have got a different connect with Nagar, madam. I was born in Ahmednagar at that time.
Oh, that's great to hear. That's
In a
great to
place like Chowpatty Karanja, the civil hospital in Chowpatty Karanja.
Yeah, I know, sir. I have my hospital in Savedi area, sir.
Okay.
Yeah.
Any experience of using Carbetocin in RH negative mothers?
So, Carbetocin per se does not have any contraindication for RH
Okay.
negative.
Yes.
Yeah. Just like routinely what we use oxytocin, Carbetocin can also be
Correct.
used in the
Correct.
active in the prophylactic management of PPH in RH
PPH.
negative
Correct.
mothers.
Now, this is very common. See, all of us use oxytocin for labor induction. In such scenario, can a doctor use Carbetocin for prevention of labor in those patients where he feel uh, PPH is possible?
So this we have used and we have not found any side effects of using two different uterotonic agents for
Correct.
two purposes. So carbetocin can definitely be used for prevention of PPH in spite of oxytocin being used for labor induction.
Plus, you get efficacy also.
Yes, yes, yes.
I mean, you have been preparing IV, but is there a place for IM route? I'm asking especially from periphery, benefit of doctors in periphery, where
The
IV
patient
facilities may not be possible.
patients are like fully dilated. We do not have time for IV access or
Okay,
something like that. When the situations are very much this thing, yes, IM route can be
IM route.
preferred.
But as a
But
preferred
the first preferred route would always be
IV,
IV.
IV, IV. Even that small difference in onset of effect will also make a lot of effect.
Yes, sir. Yes, sir.
And you have said already it's well tolerated. I mean, I
It's
don't want to
very
repeat that.
much well tolerated. Yes.
Suppose a situation occurs where you carbetocin patient, despite giving carbetocin, the patient gets a PPH. Which drugs additionally you will use?
Yes, such a situation is often seen with oxytocin also, sir.
Okay, yeah, yeah, yeah,
So
correct,
yes, the different uterotonics which can be used after that is like the carboprost injection
correct.
and the misoprostol, of course.
Yeah,
Carboprost we prefer
prostaglandins.
because immediate action is seen, and
Correct.
the misoprostol can be used for long term, like per rectal or
Yeah,
sublingual. You can give it to the
yeah.
patients.
Yeah, I mean, this is already there. The major advantage, I suppose, in our country is who does not want a cold storage chain.
Yeah, yeah.
Should it be kept as a reserve drug or as first line?
Mhm. I think it can be very much used as a first line drug, sir.
Correct, correct, correct. In fact, the condition is such, that life is at
What
stake.
happens, where the people who have been practicing since many years, you often have that fixed protocol. You do not want to switch
Correct,
over because you have
correct.
not seen any complications with that particular drug. So suddenly switching from one drug to other, you do not want to lose on, your patients for
Absolutely.
having any side effects of that. So वो एक mental block is often there, but then this I just removed it, and I could explore this carbetocin over
Wonderful.
oxytocin.
That's wonderful.
So
And
you
best
have
thing is that you have even
also.
added in your hospital protocol, in the labor room protocol.
Yeah, yeah, yes, sir.
That's it. And finally, madam, to conclude, what is your overall experience of using Carbetocin? Important take-home message for the audience.
Yeah. Uh, I would really like to say a few things about carbetocin. One is it does not have any storage restrictions. It can be kept very much at the room temperature. So we do not have to really look into all these things, or whether it was kept in the refrigerator, whether the staff is, maintaining the cold chain, whether it has been giving. No. So carbetocin, of course, has got that benefit over oxytocin. Second thing, To my knowledge, what I have used so far, I have not seen any adverse side effects of
That's very good.
carbetocin.
Yes.
And of course, whatever the cases which required additional drug, I think they would have anyways required additional
Yeah, yeah.
uterotonics, even
Yeah.
if I would have used oxytocin.
Correct, correct, correct. Right, madam. Thank you so much for taking time and sharing your experience. You know what?
Yeah,
The experience of practicing doctor helps our doctors the most. Although there are many papers, many data, many studies, but our own
yes,
doctor's
yes.
experience matters. And thank you for lovely sharing your experience and
Thank you, thank
giving confidence to our doctors. Thanks. Thank you very much. And
thank
thanks
you
for
so much.
taking time today and addressing us.
Yes,
Thanks all
yes.
the doctors who took time and attended our webinar. Thank you, marketing and sales team of Hitro. And thanks, Bhuvan, IT team, for your super coordination.
Thank
Madam,
you,
you
thank
can sign off. Thank you so much. You can sign off and
you.
very, very pleasant afternoon. Thank you so much once again. Thanks, Bhuvan. Thanks, Tanvi.